It is a pleasure coming back to my hometown, Jodhpur. I'm sorry the train was delayed, and so everything had to be postponed. And Dr. Parag had done most of the job for me when he discussed fractures of the coronoid along with terrible triad. But here I'll be talking about fracture coronoid into a bit more details. Sometimes an fracture or dislocation of the elbow, we simply reduce it, miss out the coronoid fracture, and then we realize that there's a fracture. Does this require some intervention, or can we leave it as such? It's not a terrible triad, simply a dislocated elbow. You have to understand that fracture of the coronoid alone usually indicates a severe trauma to the elbow. As has been pointed out earlier, this is not an avulsion fracture, but it signifies the trochlea sliding over and shearing off the coronoid process. And for trochlea to slide over and shear off, it requires a substantial amount of force. Rarely it can be an avulsion fracture, particularly large fragments can be an avulsion fracture, but that is really rare. A bit more into details of the anatomy. What exactly is happening here? If you look at the ulna, this portion, the coronoid, it does not just project forward, it projects up. So in full extension, this small piece of bone is the only hard structure that is preventing posterior displacement of ulna or posterior dislocation of the ulna. This is very small. As the flexion increases, the radial head starts supporting the forearm and starts preventing posterior dislocation. But in full extension, this is a small piece. And this is a diagram showing brachioradialis, which is covering the anterior portion and is getting attached here. And a bit more into details of the ligaments around the elbow. We have two ulnar collateral ligament, medial ulnar collateral ligament and lateral ulnar collateral ligament. You have to understand it. They are the major stabilizers. And when there is an injury to the elbow, one of these ligaments may be ruptured. Either a careful clinical examination, and when you suspect it, a detailed investigation will help you in identifying. So this here is the medial ulnar collateral ligament, and this portion here is the lateral ulnar collateral ligament. And see where this medial ulnar collateral ligament is attached. It is this tubercle which you identify during an anatomy as a sublimous tubercle. And the usual anatomical books show brachioradialis as being attached to the whole of the coronoid process. This is from a major book that we read, but in fact, brachioradialis does not get attached here. It gets attached a bit distally here. And a bit more into details. This is where the capsule is attached, not at the tip, but about 6 to 7 millimeters away from the tip. Brachioradialis, more than 1.5 centimeters distal to the tip of the coronoid, and then this tubercle here gives attachment to the ulnar collateral ligament, medial ulnar collateral ligament. So now, with this in mind, if you look at this fracture of the coronoid, which probably doesn't have a capsular attachment, does this require fixation? Should we go ahead and fix it? Then a bit larger, you can have, as has been classified, as has been told to you, fracture of the coronoid which is not at the tip. It is a bit larger, but still 50% or less than 50% of height, or a fracture of the coronoid which is more than 50% of its height. Do they have the same implications? Do they have to be treated separately? This is what I'll be discussing. Sometimes it may be associated with an obvious dislocation and as an important part of the terrible triad of elbow. So, as I said, the mechanism of injury is usually a twisting force or a fall on a hand when the elbow is extended. That's one of the commonest. Or in extreme flexion and twisting injury also, the coronoid may be fractured. It has been classified by Driscoll and Regan-Murray. This is very easy to remember, as we have discussed earlier. This has a type 2 fracture, which is an anteromedial facet. Now, this anteromedial facet may not look very big on a plain X-ray, but it gives attachment to one of the most important stabilizer of the elbow, that is ulnar collateral ligament on the medial side. So, when you are managing, a detailed history as to how the person has injured it, careful clinical evaluation, particularly when it is a type 1 Moraes fracture, you have to assess whether there is any sign of instability clinically. If there is any sign of instability, this requires intervention. An X-ray, of course, will give you an idea. An X-ray will of course give an idea, but what is more important is a CT scan, which give you an exact details of where the fragments have been and how the fragments have been displaced. Sometimes a small fragment like this, it is a small coronoid fracture, but this much of displacement indicates that it has also associated with a significant capsular tear. So, all these gives you an idea as to whether you want to intervene or not to intervene. Further, the anteromedial facet involvement is more clearly seen on a CT scan. MRI is important because you want to assess the basic two stabilizers of the elbow, the lateral and the medial ulnar collateral ligaments. For Moraes type 1, traditionally it is thought that if there is instability, it should be fixed. Dr. Parag had gone into details of how to do the suturing. Well, I do a simple suturing. I use simple suture, ethibond, which I make drills from the dorsum to this area, open it up from the medial side, and after making a drill, suture it back and tie the suture over the back of the olecranon. It's really simple, not very difficult to do. So, you can suture it because otherwise there's no other way you can fix this fragment. Sometimes this fragment may have gone intra-articularly, you have to remove this fragment. Nowadays, however, it has been thought that this tip of the coronoid, which does not give attachment to the capsule, still is an important stabilizer because it contributes particularly to stability in full extension of the elbow. And now the trend is that we fix all type 1 coronoid fractures. So, this suture technique has been detailed to you. I won't go into details of it. For Moraes type 2 and 3, you can simply go in and put screws, as the AO people has been advocated. Either you put the screws from here downwards, but it is difficult because there is soft tissue which come in way. So, if you can reduce the fragment and then put a screw from back forward, that is also sometimes very good. This is one of the case where after reduction of the dislocation, the fragment has become obvious, and it was found that there was an avulsion of the lateral collateral ligament. So, this screw has been used to fix the lateral collateral ligament. These screws from posterior to anterior to fix the coronoid. And this screw is to fix the osteotomy of the medial epicondyle. That can be done sometimes to get a better exposure of the coronoid when you are doing a posteromedial approach. Then sometimes you have a fracture like this, a fracture of the olecranon with a fracture of a coronoid, and simply bent cut 3.5 millimeter plate which has been put like this over here, and then this screw goes anteriorly and fixes the coronoid, particularly because the coronoid here is quite large. And this sort of simple plate has also been recommended, where it can be used on the anteromedial aspect to buttress the coronoid process. There are a few incidences where either the coronoid process is so badly damaged, particularly the small fragment, or the patient is not fit for surgery, or in spite of surgery you find that the elbow is unstable, then a hinged external fixator may be used. Hinged external fixator allows for limited movement. Whenever there is instability, if you immobilize the elbow for more than 2 to 3 weeks, chances of stiffness which does not recover with physiotherapy is very high. So hinged external fixator or a slab which allows movement from 30-degree extension to flexion, because beyond 30-degree the whole forces get concentrated over the tip of the coronoid and it can further cause its displacement. So that can be done for about 3 to 4 weeks, and then gradually full extension can be carried out. As I said, duration of immobilization is directly proportional to the stiffness, and physiotherapy is very, very important. In my town, if I send a patient to the physiotherapist, they come every week to me with gradually increasing stiffness of the elbow. So initially I was at a loss, then I stopped sending them. I found that these simple measures, what they do, they are not well trained. They go ahead and try to mobilize, to do a passive stretching, passive mobilization of the elbow. That should never ever be done. It has to be an active and an active resisted movement that has to be carried out. A patience has to be kept, because these patients improve very, very gradually. Cold compresses help in reducing inflammation, help in reducing heterotrophic bone formation. Along with it, course of indomethacin helps. As I said, physiotherapy is very, very important if you want to have a good result after these injuries, which are not simple fractures of the coronoid, but most of them are associated with major ligamentous disruption. You have to assess the ligamentous disruption along with fracture coronoid, and not only fracture coronoid but ligamentous disruption has to be addressed. Thank you.